Hi folks, and welcome again to the series of lectures for MDSC 2409. Today we'll be talking about medical negligence and very briefly about the duty of candor. I'll skip a few slides for this lecture. I don't want to go too much into the, we covered these slides in the lecture already. What is the scope of the problem in terms of financial aspect of it? Just to reiterate the regional experience, in Trinidad here in 2015, a widow was awarded $18 million after her husband died post-transurethral resection of the prostate, and both the hospital and the anesthetists were made liable. And as recently as 2020, a patient suffered postpartum cardiomyopathy, cardiac arrest, and hypoxic ischemic encephalopathy, and was awarded general damages of $900,000 TT and at 5% per annum. And the actual injury occurred in 2013. She was awarded special damages of $100,000 US, additional damages of 2.5% per annum, and then 1 million EC dollars for future loss of earnings. Right. So it's from a financial aspect, medical negligence is quite a serious issue. Why the increase in medical negligence cases? We have advances in modern medicine, and sure, medicine as a result of these advances, medicine is considerably safer. However, associated with these advances, you have an increased chance of injury, which does occur. Along with these first two factors, there's greater patient education, coinciding with the rise of the internet and social media. So along with this, hand in hand with greater patient education, there's a greater awareness of patients' rights. Unfortunately, with the rise of social media and the internet, patients now have expectations of a total cure when they visit their physician. There's a culture of compensation. There's increased media exposure when medical negligence cases do occur. So again, this contributes to greater patient education and greater awareness of their rights. And the courts are not as deferential as they used to be in previous years when cases of medical negligence do occur. So they do have medical negligence does have its consequences. We mentioned the economic consequences, how expensive it is from a public health point of view for medical negligence cases to be settled. There's a political angle. When all this money is spent settling medical negligence cases, there's less money for healthcare. So the rest of the public suffers. I mentioned increased coverage, media exposure of these medical negligence cases. So when this happens, there's breakdown at a public level of the doctor-patient relationship, where the patients don't trust the doctors as much. It makes medicine increasingly defensive, and so in an effort to deflect or from potential medical negligence cases, medical professionals now order more tests in an effort to cover themselves. And of course, the more tests you order, the more money that's spent. So again, it goes back to there's less money for healthcare, right? So just a strict definition of what defines medical negligence, and there are three core elements of any negligence action, and any claimant who launches a medical negligence suit must establish all three conditions to be successful. So you can't just have one or two out of three. All three must be met. So the first condition is that the defendant owed the claimant a duty of care. The second condition is that there was a breach of this duty of care, and by a breach of this duty of care, we mean that the claimant must demonstrate that the standard of treatment delivered by the claimant fell below the standard expected by law. And the third and final condition is that because of this breach of standard of care, the claimant suffered a legally recognizable harm, which is either physical or psychiatric, right? And when it comes to compensation, we saw the level of compensation in one of the slides previously. If successful, the claimant is entitled to compensation, and the aim of the courts when determining compensation is to place the patient back as far as possible to the position he would have been had the breach of duty not occurred. So going back to this slide, you can see the rationale for having for compensating the patient for future loss of earnings. Okay. So just going into examining these three conditions, when you talk about the duty of care, uh, the duty of care is a doctor refers to the doctor-patient relationship, and this duty is implied by law. This holds true for a public health system as well as a private hospital. So once any public or private health institution holds themselves out as having offering emergency services, once they accept the patient into the institution, then they are obliged to provide the patient with a duty of care. So private doctors don't escape a duty of care, right? So we move on to the second one, the standard of care. So the standard of care is that of the ordinary skilled man or woman exercising that particular skill, and he or she is a practitioner who, one, follows the standard practice of his profession, two, has a reasonably sound grasp of current medical techniques, and three, is as informed of new developments as the average competent doctor. So the standard is that of the averagely competent doctor, is not the professor of a particular subspecialty, right? So when you're assessing the standard of care from a legal point of view, you perform what is called the Bolam test. So one, it must be proven that there is a usual and normal practice, and that's the norm. That usually occurs with any medical procedure, any medical treatment, right? It must be proven that the defendant did not follow that practice, whatever that practice is, and it must be proven that the course of action is one which no professional of ordinary skill or any averagely competent medical professional would have taken had he or she been acting with ordinary care, right? So this is a quote from the original um, case, the Bolam case, and the judge said the test is the standard of the ordinary skilled man exercising that skill. A man or woman need not possess the highest expert skill. It is sufficient if he or she exercises the ordinary skill of an ordinary competent man or woman exercising that particular art. So the defendant doctor will be tested against the standard of doctor in his or her particular specialty. And the third condition that is often the most difficult hurdle for the claimant to clear is causation. So as a result of that breach of standard of care, the patient suffered legally recognizable harm. And there must be a direct relationship between that breach and the cause of the and whatever harm the patient sustained. And he or she must prove that the breach of duty led to recognizable harm. Causation is difficult to prove because of the multifactorial nature of various medical conditions. So can the claimant convince the court that it was the relevant negligence which caused his or her harm rather than the progress of the original condition or disease? And can the claimant prove that as a result of the negligence, it deprived him or her of a full chance of recovery? So we talked about these cases in the lecture. Barnett versus Kensington. The doctor did not attend the patient who presented in the middle of the night with nausea and vomiting and gave telephone advice instead and advised the patient to return the next day. The patient subsequently died, however, as a result of arsenic poisoning. However, he wasn't found liable because of the nature of arsenic poisoning, and it was held that even had he come out and seen um, the patient would have died from arsenic poisoning anyway. So there was no causation between his failure to come out and attend to the patient and the patient's subsequent death. With Kay and Aaron, a 2-year-old boy with meningitis was given a massive overdose of intrathecal penicillin, was sustained a cardiac arrest, resuscitated, and made a full recovery but sustained bilateral deafness. The health board was not considered liable again in this case because even though he was given a massive overdose of intrathecal penicillin, in the judgment of the court, what was the overriding cause? What was judged to be the overriding cause of his bilateral deafness was his meningitis that he had presented with in the first place, right? So it was more likely, much more likely, that it was a meningitis rather than a massive overdose of intrathecal penicillin, which causes deafness, right? And then in Wilshire versus Essex, this premature infant was given excess oxygen and developed retrolental fibroplasia. And again, it was the health authority was not held liable because again of the fact that the infant was premature, and it was held that it was his prematurity and the progress of his original medical condition, his prematurity, which would have caused his retrodental fibroplasia and not the administration of the excess oxygen, right? So sometimes, so we can see the difficulty of patients, of claimants, trying to prove causation, right? Because of the progress and the nature of the original disease. This GP practice case, they failed to refer an infant with sepsis, and they were held liable because it was a very straightforward criteria to follow for diagnosing sepsis, and they did not refer the infant to the hospital, and the patient subsequently died. You can't be held negligible for prescription errors. So Dwyer versus Roderick, there was an overdose of an old, which is not used anymore, but vasoconstrictor dogotamine, which was prescribed leading to gangrene. So these doctors were held liable because of the overdose of vasoconstrictor. And poor handwriting, doctors are notorious for having poor handwriting, so don't think that this poor handwriting doesn't have consequences. In this case, Prendergast, Deonil was substituted for amoxil. Deonil is a very old hypoglycemic used to treat diabetes. It is not used very often anymore, but it was substituted. But the handwriting was substituted for amoxil, an antibiotic. So the patient, instead of getting his antibiotic for his chest infection, got his anti-hypoglycemic, became hypoglycemic, and suffered brain damage. And of course, so this was negligent, found to be negligent. And special situations, doctors can be convicted of manslaughter. So it can become, so medical negligence is normally a civil matter, a civil case. However, if the degree of negligence is gross, particularly gross or egregious, doctors can be convicted of manslaughter in a criminal court as well. Right? So just a brief mention about the duty of candor. Somebody had asked, do I admit a mistake? If I do make a mistake, a medical error, and admit it, am I supposed to admit it to the patient? Will I not be held liable or negligent if I admit it to the patient? So as a medical professional, there's a duty of candor. So you are obliged as a medical professional to reveal any medical errors or medical mistakes to the patient. This has been put forward by the GMC, so it's something that you all should follow. You won't be held negligent for admitting a medical error, and if there is a subsequent case in court, it will look very poorly on you if you've been discovered to be hiding information from the patient, right? So that's a brief mention of the duty of candor. Okay, well, thanks for your attention as usual, and this is the end of this medical negligence lecture. Thanks again.